Good morning. My name is Alexander Peters, and I'm a research fellow at the Program in Global Surgery and Social Change at Harvard Medical School, as well as a general surgeon in New York at Weill Cornell Medical College. I'm here to talk to you today about national surgical, obstetric, and anesthesia planning, how it relates to Pakistan, and how these efforts have progressed around the world. Surgical care actually came to the forefront for the global health community going back to 1980, when the Director General of the World Health Organization, Haften Mahler, declared that the vast majority of the world has no access to skilled surgical care whatsoever. He called this a serious manifestation of social inequity in healthcare. But it wasn't until 2015 when surgery really got on the map. In that year, the Disease Control Priorities third edition came out and dedicated its entire first volume to essential surgery. In the same year, The Lancet put forth its Commission on Global Surgical Care, and at the World Health Assembly, Resolution 68.15 was passed, calling for strengthening emergency and essential surgical care as a component of universal health coverage. Since then, as we lead into 2019, surgery is beginning to be seen as not only a part of UHC, but as an integral aspect of achieving the Sustainable Development Goals. For surgical care does not only impact SDG 3 for good health and well-being, but actually cross-cuts a number of the SDGs, reducing poverty, gender inequality, and other efforts. So in 2015, the Lancet Commission on Global Surgery came out, and it put forth a vision for the world for universal access to safe, affordable surgical and anesthesia care when needed. And with that report came 5 key messages about surgery, 6 data indicators, and a framework for national surgical planning. The report found that 5 billion people around the world lack access to safe, affordable surgical and anesthesia care when needed, that 140 million additional procedures are needed to fill that unmet need, that 81 million people are at financial risk for catastrophic expenditure when they seek surgical care every single year, that investment in surgery and anesthesia saves lives, is affordable, and promotes economic growth, potentially to the tune of $12 trillion by 2030. And finally, it concluded that surgery, obstetrics, and anesthesia care are indivisible, indispensable parts of healthcare. It also put forth 6 surgical indicators, like 2-hour access to care, density of surgical providers, volume of procedures done per OR in a given country, the perioperative mortality rate, and indicators around impoverishing and catastrophic expenditures. And the Lancet Commission called on countries around the world to collect and report on these indicators as benchmarks for their surgical systems. These indicators, 4 of them, have been taken up by the World Bank and the World Development Indicators and are reported on. And they've been blogged about by the World Bank and tweeted about by the World Bank. And finally, the Lancet Commission put forth a framework for national surgical, obstetric, and anesthesia plans, also known as NSOAPs. And this process, which I'll talk more to you about, has been completed in a number of African countries, is in process in Pakistan and several other African countries, and has been committed to in an even larger number of countries around the world. The National Surgical, Obstetric, and Anesthesia Planning is built on the World Health Organization's health system strengthening building blocks, and it maps those very closely. First, you have access to essential medicines, and that links to the infrastructure pillar. As in surgical care, we don't focus as much on essential medicines as we do on essential infrastructure. The second pillar is workforce. The third pillar is service delivery related to surgical volume and system coordination. The fourth is financing. The fifth is information management and health system information systems. And the last is governance. And these pillars match the World Health Organization's building block system. The development process of national surgical plans is an iterative process that starts with planning and identifying key stakeholders, then holding national and provincial surgical forums, and moving on to implementation, engaging with funders, prioritizing different pieces of the system, engaging feasibility of impact. And this system then iterates round and round as you get closer to surgical system strengthening. So developed an NSOAP It's meant to fit in along with any other health policy strategy in a broader national health vision. So in Pakistan, for example, the National Vision for Surgical Care would potentially fit within the National Health Vision 2025. In going forward, to create a national surgical obstetric or anesthesia plan, or the National Vision for Surgical Care, there's a strategic approach that follows an 8-step process. The first of that is ministry support, which we got in November when we started the launch of the National Vision for Surgical Care in Islamabad. Moves on to the next step, which is situational analysis and baseline assessment. This is a very important step to give you a sense of where a country is. It starts with things like hospital assessment, literature review, and an analysis of countrywide data on those 6 indicators we discussed. The third step is stakeholder engagement and priority setting. That's part of what we hope to do today in each of, and this week in each of the provinces. When we launched the National Vision for Surgical Care back in November, we engaged several stakeholders, including ministry officials, clinical providers, civil society, funding bodies, and implementation bodies, and discussed all of these different pillars: infrastructure, finance, service delivery, workforce, information management, and governance. And we had committee meetings about those things. So taken here, for example, when we discussed infrastructure, we looked at the background about surgical facilities, challenges, and proposed solutions for those shortcomings. We talked about targets for Pakistan and also discussed potential monitoring and evaluation frameworks. Now, this process isn't complete, and in each of these provincial meetings, we hope to engage local stakeholders to know what's important in that province. The fourth step of the NSOAP process is drafting and validation. The fifth step, which is incredibly important, is to establish a monitoring and evaluation plan. There are a number of different ways to do this. This can focus on the Lancet indicators. It can be focused on the NSOAP pillars, or it can follow something like a Donabedian framework where you look at structures, processes, and outcomes when you analyze a health system. Next is costing, the implementation of the plan. This slide is an example of the Tanzania costing process when Tanzania completed its national surgical plan. And as you can see, every one of those pillars is line itemed across every single year going forward. And a cost is estimated for what it would cost to scale up the surgical system in that year. In Tanzania, we found that $1.7 per capita per year, accounting for 3.28% of total health spend, would be enough to cover the national surgical, obstetric, and anesthesia planning process. The last 2 phases of the NSOAP theoretical framework and the process development is governance and implementation. So one example governance model for the NSOAP process would be to have provincial steering committees with provincial coordinators who interface with the national steering committee. And as they interface back and forth, they discuss the needs in each particular province and together work towards pushing forward both the national and provincial surgical system. In the implementation phase, a province might have community or TESOL-based health referral systems that then refer to first-level hospitals and higher hospitals within the provinces. From a national implementation process, the National Ministry of Health might try to work with large international funding bodies, multilateral organizations to work towards financing the National Surgical Plan. NSOAPs ultimately are an adaptable and customizable process. That framework that I just went over is just an example stepwise framework of how to develop a national surgical plan, and it's something we've started to follow here in Pakistan with the Indus team. In Tanzania, for example, they did follow a similar model. They started with a systematic literature review. Then they went to stakeholder meetings with clinicians, civil societies, NGOs, end users, as well as the government. And they held technical workshops with participants over several days and broke it down into several groups. Then they moved on to writing. They wrote the plan, they costed the plan, and they put forward a final draft, which was launched in the spring of 2018. In Pakistan, with the National Vision for Surgical Care, This is the process map that we followed. First, we put together a steering committee for the National Vision for Surgical Care, as well as a technical working group. In November, we had a national stakeholders meeting in Islamabad, which some of you may have attended. From there, we put forward the National Vision for Surgical Care consensus statement that was agreed upon by the participants of the November 2018 Islamabad meeting. And then the technical working group and the steering committee have been working hard since that time to put together a draft of the National Vision for Surgical Care 2025 document. This document, which we're reviewing today and has been sent out to each of the provinces, is meant to be a national guiding document for which each individual province could develop its own, what we might call a PSOAP, a Provincial Surgical Obstetric and Anesthesia Plan that's customized and tailored to the needs of that province, because no national health plan fits each province the same way. So this is where we are today. Ultimately, many of the tools that we use are available on our website at thepgssc.org. But we're excited to be here and to work with you on this plan. So thank you very much for your time. In the drafting and validation process, the first step is to synthesize process recommendations, then to draft the plan. Then once you've drafted the plan, as we've done with the National Vision document, to send that for stakeholder review, as we're doing in each of the provinces. And then, once stakeholders reviewed it, to finalize the plan, publish it, and disseminate it for all interested in the surgical policy.